Hello, everyone, and welcome to the Musella Foundation's Brain Tumor webinar series. Tonight's topic is oral gallium maltolate, and our special guest speaker is Dr. Jennifer Connolly. Dr. Connolly is board certified in internal medicine, neurology, and neuro-oncology, and she is the principal investigator for the phase 1 clinical trial on gallium maltolate at the Medical College of Wisconsin. In addition to Dr. Connolly's presentation, we're also going to hear from 2 patients who are participating in the trial and have generously volunteered their time tonight. To the audience, we will have a Q&A portion at the end of the presentation, so please feel free to type your questions into the chat. Dr. Connolly, go ahead.
Wonderful. Thank you for the kind introduction and the opportunity to speak to you this evening. I am going to talk to you this evening. It's a short talk, but it seems initially as if it's 3 separate little conversations. First, I'm going to touch upon glioblastoma, and I know this audience is well familiar with this disease. But then I'm also going to do a little refresher in chemistry, and then touch upon gallium. And I promise by the end, it's all going to come together to really help us understand gallium maltolate, which we abbreviate GAM. So glioblastoma is the most common primary malignant brain tumor. This is a very sort of typical MRI scan where we see this large heterogeneously enhancing mass. When we look under the microscope, there's a couple hallmark features that we look for. We look for mitoses, which is cell division. There's way too many cells on this slide in the lower left-hand corner. We also look for an entity that's called endothelial proliferation. But then the other thing that is a hallmark feature of glioblastoma is something that we call pseudopalisading necrosis. And what you see is this line of blue cells. These are tumor cells lining up. And in the central portion is necrosis. It's a lighter color. So I want you to just tuck this in the back of your mind. We're going to circle back to that in a few minutes. When we think about standard of care for glioblastoma, there's been a few advances in the past couple of decades. It really started in 2005 with what we call the STOOP protocol, which is the radiation with temozolomide followed by maintenance temozolomide. Several years later, we were introduced to bevacizumab, and we were all very excited about how it melted away tumors on the MRI. But when we looked at overall survival, we didn't see much difference. And then the most recently FDA-approved treatment for glioblastoma is actually a medical device called Tumor Treatment Fields, and this also demonstrated survival benefit. So when we look at the standard of care for glioblastoma, it starts with maximal safe resection, followed by radiation with temozolomide, and then maintenance temozolomide with TT fields. So shifting gears just a little bit, many of us have had some sort of chemistry either in high school or college. And I want to just touch upon a few basic principles, or at least refresh everyone's memory. So this is the periodic table, and there's some fundamental principles about this table. And the first thing that I want you to remember is that all these elements in the similar row share the same or similar physical properties, versus elements that are in columns have similar reactive properties. And that's all you need to know about the periodic table for tonight. So keep that in mind. When we think about elements, one of the most important elements in the body is actually iron. We all need iron to survive. It is essential for all many intracellular processes. And it's a tightly regulated element. And it's depicted here in this picture. Iron is bound to transferrin, and it enters into the cell through transferrin receptors. Now, I'm not going to get into all the details of what happens in the cell. It's important to know that iron is stored in these pools within the cell. And then as the cell needs iron to fuel different cellular processes, it will release it out into these areas. And like any system, when you have an import, you also have to have an export. And that's what we have here with hepcidin. So to simplify this picture, you can look at this schema. You have an import, you have an export, you have a certain amount of iron storage. So like I mentioned, iron is important for all intracellular or all cellular processes. It's also important for cancer. And what scientists have shown over the years is that the amount of iron actually is correlating with the aggressiveness of the cancer. In this picture here, this study was looking at breast cancer. And what they found was that the iron import system, these transferrin receptors, were actually increased in number, and the amount of export was actually decreased. And what that results in is an increase in this iron pool. And the reason the cancer needs more iron is it needs to fuel all these processes that depend upon iron that lead to increased cell division. So it begs the question, as a neuro-oncologist, is do we see the same thing in glioblastoma? And we do. So remember that picture of that pseudopalisading necrosis that is a hallmark feature of glioblastoma? When we stain for transferrin receptors, the iron importers, we can see that the tumor cells also have increased expression in that regard. We took it another step as well. So not only do we see the expression with glioblastoma, but when we look at the different grades of astrocytoma, the higher the grade of the astrocytoma, the higher the transferrin receptor expression. It also correlates with overall survival. So the higher the transferrin receptor expression, the lower the overall survival. Iron in the brain is also tightly regulated. And we know this because the brain vascular endothelial cells express transferrin receptors that allows the iron to go in and out. But when you look at the endothelial cells outside of the brain, they do not express that transferrin receptor. We, in our own lab, looked at that expression and confirmed that, again, transferrin receptor is upregulated or is present in those endothelial cells in the brain. And what this creates is sort of this perfect environment of a glioblastoma cancer cell looking for iron. So again, you have a cancer cell that wants iron, and the brain is rich in iron because of this transport system. We also confirmed that glioblastoma cells have that increased iron expression, but we looked at other iron biomarkers as well. So one of them being ribonucleotide reductase is also increased in glioblastoma. And you also have ferritin, H-ferritin and L-ferritin, which within the tumor cells here are upregulated. So that takes us to gallium. So why are we really interested in gallium? What makes us intrigued? Well, that takes us back to the periodic table. So to show you where iron is located, it's located here, and gallium is just down the row. And so if you recall, elements in the same row share similar physical properties. So gallium and iron are similar in physical shape. So they both will bind transferrin. They both are incorporated into cells through transferrin receptors. But because gallium is located in a different column, it doesn't share in the same reactive properties that iron does. So once gallium is within the cell, it doesn't fuel those iron-dependent processes that cells need to continue to grow. We think about this as sort of the Trojan horse phenomenon. You have cancer saying, I need more iron to grow and to replicate. And so it's looking for transferrin because that's what brings iron into the cell. But if someone has gallium in their system, it is bound to transferrin. Cancer thinks it's bringing iron in, but it's actually gallium is sneaking in. Once gallium's within that cell, it isn't fueling those iron cellular processes. So one of the first gallium compounds that was studied in cancer was actually a drug called gallium nitrate. Now, gallium nitrate was an IV infusion. There were several phase 2 clinical studies looking at various solid organ tumors that were refractory to treatment. This did not include brain tumors, but there was a couple cancers that seemed particularly sensitive to gallium nitrate. Patients tolerated it really well. There was no significant toxicity. But the challenge is gallium nitrate needed to be infused over 5 to 7 continuous days. And so that required a stay in the hospital. And while it seemed to have some benefit, it just was logistically not feasible. The next gallium compound to be studied in cancer is actually gallium maltolate. And much of the early work was actually done by Larry Bernstein. And you can see here, this is gallium, the element, and attached to it are 3 sugar molecules. And by having those sugar molecules, this became a compound that could be taken orally. So this was also studied in a preliminary or an early phase 1 study looking at, again, solid organ tumors that are refractory to treatment. It did not include brain cancers, but it was the first study with gallium maltolate in which patients took this medication orally. They started low at 50 milligrams per day and then gradually increased to 500 milligrams per day. And what they saw was that patients generally tolerated this medication well. There was no significant toxicities, and including laboratory toxicity or symptoms. Now, the study of gallium maltolate sort of fell to the wayside. The company chose to pursue another agent that they were investigating at that time, and that just didn't work out. So this is the only phase 1 sort of study outside of brain cancer that was performed. But that leads us to gallium maltolate and the experience here at the Medical College of Wisconsin. And this actually goes several decades back, and it starts with Dr. Chris Chitambar, who nearly 3 decades ago started studying gallium maltolate in his lab. And his focus was really looking at what is the mechanism of action? How does gallium maltolate work? And there was a number of discoveries he made. I'm not going to get into the details of that just in the interest of time. But we do know one of the major mechanisms of action is actually working on mitochondrial complex 1. When we think about glioblastoma, that research didn't really start until recently in 2013. And this was due to collaborations between Dr. Chitambar and Dr. Kathleen Schmenda when they started looking at the preclinical animal studies. And then 9 years later, we opened the first phase 1 clinical trial. So touching on the preclinical work that has been done with gallium maltolate in glioblastoma, when we're studying and investigating, potential new treatments in cancer, we start with cells in culture. And what we did is we took 2 glioblastoma human cell lines, the D54 and the U87, and we exposed them to gallium maltolate. And we saw was the rate of growth was substantially decreased in those that were exposed to gallium maltolate versus our control agents up here. The next step is we actually had the ability to study glioblastoma stem cells in 3D culture. And you can see here in this top example, this is the control. So at 24 hours and then 3 days later, seeing the significant growth of the GBM stem cells. When exposed to gallium maltolate, you can see that there is a significant reduction in the volume and rate of growth. The next step is looking at gallium maltolate in animal models, in our xenograft models. And in these cases, we used rats, and we would actually implant the human-derived GBM cells into the animal's brain. MRI would then confirm that the tumor had taken. And this is an example of one of the control animals on day 36. And typically by day 36, the tumors would be quite large in size. This here is the MRI T1 with contrast. This is a delta T1. It's looking at the difference between T1 and T1 with contrast. It makes the contrast enhancement a little bit more apparent. And then in the bottom panel here is MR perfusion, looking at the hypervascularity, which is a common finding in glioblastoma MRI imaging. So this is our control animal on day 36. This here is an example of an animal that received gallium maltolate, actually received oral gallium maltolate. And you can see in this picture, the tumor is much smaller. There is evidence of tumor that's there, but it does not have the growth rate that we would see in an untreated animal. And in fact, it wasn't until day 70 that we started to see some substantial tumor growth. When we look at all of our subjects who received gallium maltolate, we saw that there was significant reduction in the volume of tumor and the rate of growth. And then we also noticed, or we found that animals that received gallium maltolate lived longer compared to the control arms. And both of these were statistically significant. We had one particular subject. I think we all have this in clinic with our patients, in that you always have patients who break the rules or do exceptionally well. And we had an animal that did just that. And this was an animal that was receiving gallium maltolate. And on day 43, the MRI showed this increase in contrast enhancement, which, looking at the MRI itself, is worrisome. But the thing that was different was this animal was behaving normally, was eating and sleeping normally, didn't have any kind of focal neurologic deficits. And so we continued to follow. And what we saw was that the MRI actually showed near complete resolution of this abnormality. When we looked under the microscope, we could see areas of treated tumor, but in the histology, there was no evidence of recurrent or residual tumor. So we see this entity in clinic. We call it pseudoprogression, where sometimes the MRI looks worse before it starts to look better, and it's consistent with a treatment effect. And so we think this animal had pseudoprogression and was actually responding to gallium maltolate. So based on all of this, research that was done that took several years to do, we felt that the next step was really moving it into a phase 1 clinical trial. And that's where we're at right now. So nearly 2 years ago, we opened the phase 1 clinical trial for recurrent glioblastoma. And like so many phase 1 trials, the purpose of this trial was to look at safety and tolerability, and really to identify what is the maximum tolerated dose to then lead into a phase 2 clinical trial. We started our dosing at 500 milligrams per day based on one of those initial phase 1 trials done with gallium maltolate. Our initial trial design was to dose titrate up to 1,500 milligrams per day. But since patients seemed to tolerate it really well and had no toxicity, we added 2 additional dose levels to the clinical trial. This here is a picture of the gallium maltolate. They're 500 milligram capsules. We have patients take gallium maltolate on an empty stomach because the food-drug interactions hasn't been clearly defined. At our SNO conference, our Society of Neuro-Oncology conference last November, we presented some interim analysis. And to date, we had 16 patients enrolled. 10 of them were male. 5 of the patients had MGMT methylation, and 3 of the dose levels were completed. And what we found is that there have been no dose-limiting toxicities. Patients tend to tolerate it well. Patients will often comment to me that they find it easier than chemotherapy that they had received previously. There was also no significant laboratory toxicities. When we look at hemoglobin, it does have a trend towards a decrease, which is not surprising because we're interfering with iron. But it's important to note that none of these patients had symptomatic anemias or needed a transfusion. Along with the hemoglobin decreasing, we also saw the decrease in MCV. This was one of our signs, though, that the gallium was actually being absorbed by patients. We also monitored for other laboratory toxicities, and really there was no electrolyte abnormalities, and none of our patients had renal impairment. At the time of our interim analysis, we had 5 patients who had progression-free survival greater than 180 days, and we had 1 patient who remained on treatment for more than 15 months. So hopefully this overview, you can now see how these 3 seemingly unrelated subjects actually can come together to make an interesting concept of gallium maltolate and really how it does have the potential to work for treatment of glioblastoma. I do have to say this has been a marathon. Drug development never happens fast enough, and as much as we wish it would happen overnight, it doesn't. But we've made significant strides in really a short period of time. So our preclinical work for gallium maltolate in glioblastoma started in 2013. We had the first publication of gallium maltolate in GBM come out in 2018. We opened the clinical trial in March of 2022 and enrolled our first patient shortly thereafter. Along the way, though, we've been continuing to push forward, even outside of just working on the phase 1 trial. Last February, we received FDA orphan drug designation for adult and pediatric glioblastoma. And then most recently, we received fast track designation in December of 2023. So we have much to do. We have a lot that we're looking forward to in the future. One of our biggest focuses right now is the EAP program, or Expanded Access Program, to allow patients who are not eligible for clinical trial opportunities to receive gallium maltolate when they have no other treatment options. We are working on developing the phase 2 clinical trial to follow up our phase 1 trial. And then we've done some preclinical work in the pediatric brain tumor population, and we're currently in the early phases of designing our clinical trial for pediatric brain tumors. So this is a marathon, and it takes a team to run a marathon. And so I have to acknowledge Strain for the Brain and Chasing Chad, who helped fund some of the initial preclinical work done with gallium maltolate at the Medical College of Wisconsin. And of course, the Musella Foundation, who has supported us along the way, and especially with the phase 1 trial, IQAI and the Freighter and the MCW Cancer Center Foundation. Also have to thank, I have a huge team behind me. This is not just my work. This is definitely a team effort and collaborative effort from the beginning. But a special thanks to patients who are willing to entrust us in their care and participate in research to help us try to find that next best treatment. So thank you again.
Thank you, Dr. Connolly. And actually, that's a perfect segue, thanking our patient participants, because we have 2 patients from your trial on the call today. And we're just going to ask them briefly to share, when they were diagnosed, what their treatment journey was that led them to your trial, and what their experience has been so far in the trial participation. So I think, Linda, if you can come off mute and turn on your video, we'll give you the floor for a couple minutes.
Okay, sounds great. My name's Linda. This is my husband, Al. And I would say 2.5 years ago?
Approximately.
2.5 years ago.
She doesn't remember much.
I don't. I must have been really out of it. So my daughter and my husband thought there was something wrong with me, and eventually my husband took me into Freighter Hospital because I was not making any sense. So I'm gonna let you talk about that.
Well, in retrospect, her actual diagnosis wasn't until January 28th of 2022. But there were the symptomology earlier, I guess, were red flags that we probably all missed. So she had her first surgery to remove a 7 centimeter tumor, I think February 2nd of 2022. MRIs, radiation followed, chemo pill. And then in July of that same year, 2022, an MRI showed either some regrowth and or scar tissue. So to be on the safe side, Dr. Max Krukoff suggested another surgery, which went way better. She was awake during the surgery, which allowed him to be much more aggressive. And he thought he'd gotten everything he needed to get. And in October, we started on the trial, I believe, with Dr. Conley. So, and it's been, the MRIs have been very positive since then. So it's going on. Well, it was a year in October of 2023 that she's been on the trial.
Okay, and Linda, what's your experience with the treatment? You know, how do you feel taking it?
I feel great taking it. I have not noticed any negative things about it. Haven't had any, of the diagnoses that other patients have. So I'm happy to take it. And it's been really great. So I said to my husband, I finally feel like a real person now. So it's been really fun.
That's wonderful. And so I guess you enrolled in October 2022 or 2023, I'm sorry.
Correct.
Okay.
It was October 2022.
2022. Yeah, I'm sorry.
2022. Okay, so it's been well over a year now. Okay.
Correct.
Okay. Wonderful. Thank you so much for sharing, Linda.
Thank you.
That's great to hear, and I'm so glad you're doing well.
Thank you.
Samantha and Tim, do you want to come off mute and come on video?
Sure thing.
Hi, so I'm Samantha.
I'm Tim.
This is Tim, and I told him I would tell his story. So he got his first symptoms in September of 2022, what we thought were migraines, his first ever migraine. And within that month, he had 11 migraines, and we started noticing just some weird things, him seeming confused, balance issues. And so he was then diagnosed with GBM in October of 2022, had surgery in October, and then he had another one. The first one was kind of more of just like a biopsy. Then he had one in the beginning of November. That one caused him to have a stroke. So he still is dealing with left side weakness. So he was in a rehab facility for 6 weeks from November to December of 2022. And while in the facility, he did start radiation and chemo, the standard of care. So he finished that in January of 2023. And then in February of 2023, he started the Temidor 523 and then also started Optune, which we were certainly willing to try everything. For him, that was a little bit challenging because of the left-sided weakness, and kind of created a little bit of a safety concern for us. So, but then in March of 2023, he did have a recurrence. Oh, my daughter hears us talking.
No worries.
In March of 2023, he did have a recurrence. He had surgery again in April of 2023. And then in May, we had 3 options to choose from, 2 of which included a chemo, and that was hard on him physically, obviously, when he was doing the 523. And one of the options also included Optune again. And so we were just kind of weighing, what was going to be the best for him. So we decided to go with the trial, and we've never looked back. It's been a great decision for him. He's had no side effects. So we're just so thankful. Yeah.
Okay, that's so great to hear. And so then I guess from May 2023, you're probably coming up here on a year.
Yep,
It's
exactly.
fantastic.
Yeah.
Well, thank you so much for sharing. Feel free to turn off your video and go on mute if you'd like. We have quite a few questions in the chat, but I think most of them are directed to Dr. Connolly for now. So Dr. Connolly, I'm just going to start with the phase 1 recurrent GBM trial. Can you just give some logistical details about, where is the trial available and what's the main inclusion exclusion criteria?
So when we designed the clinical trial, we left the inclusion and exclusion criteria very wide open. We want it to be all inclusive. So the patients have to have had either a histologic glioblastoma or even a molecular glioblastoma, which some people may be familiar that just because under the microscope it doesn't look like a GBM, they can have molecular features that are consistent with a GBM. They have to have had radiographic recurrence, and they may have undergone a second surgery or an additional surgery or not. Surgery is not required. They had to have received the standard of care up front, which is radiation and temozolomide. And that is the significant sort of inclusion and exclusion criteria. Patients have to have a reasonable performance status and be willing to travel to Milwaukee. So the clinical trial is currently only available at the Medical College of Wisconsin, which is located in Milwaukee.
Okay, and you mentioned at the interim analysis you had 16 patients enrolled. Are you still enrolling and up to, what number of patients?
Yep. So we are currently enrolling or about to reopen. We just did another sort of interim analysis looking at toxicity before we formally increase to that next dose level. But there are still opportunities to enroll in the clinical trial, at least 3 more patients, potentially another 6 patients after that.
Okay, and if patients are coming from out of state, how often would they have to travel to Wisconsin to participate?
Yep. So initially, the clinic visits for the first month is once every 2 weeks, and then clinic visits with myself or my team is monthly. Laboratory testing is done once every 2 weeks, and those labs have to be done at the Medical College of Wisconsin because not only are we looking at standard labs like iron and hemoglobin, but we're also measuring the gallium levels, which is really important for the clinical trial. But after patients have been on trial for 4 cycles, the laboratory testing and the reduces to once a month along with the clinic visits. So
Okay, and those cycles are how long?
one cycle is 28 days.
28 days. Okay.
Yeah.
And you mentioned in the mouse study that you showed that example of pseudo progression. Are you also seeing that in the phase 1 clinical trial?
So we are monitoring that for sure. So when we interpret the MRIs, if we see small change, but patients are doing well, we do continue to monitor. And there have been some situations where we see some small changes initially, but then things just seem to stabilize. What is most important is really how patients are doing. And, certainly if they're tolerating drug well and we're not seeing significant changes on the MRI, we really do give them the benefit.
Okay. And you also mentioned from your patient population so far, you had 5 MGMT methylated patients. Like theoretically, that shouldn't matter for this trial, right? Your MGMT status.
It's interesting. We're definitely looking at it and trying to understand if there's some science behind why those patients may be more sensitive to gallium maltoate than others. But at this time, we have nothing to suggest that it is only beneficial to gallium maltoate patients. I'm sorry, it's only beneficial to MGMT methylated patients or not. And it's certainly our primary focus is looking at toxicity, but you're absolutely right. You're looking for some sort of other indicator that we're working against tumor.
Okay. And you know, you had gallium nitrate tested across a number of malignancies in the past. Now that you have this phase 1 in GBM and you're seeing a very good safety profile, do you think that oral gallium maltolate will then be, translated to other cancers and other, phase 1 trials?
We certainly have been having those discussions, especially since we know that it has brain penetration or we are suspecting it does, because we have this whole world of brain metastases that involve all these other malignancies in which there's potential treatment opportunities in that regard. And, as we're working on the pediatric protocol, we are talking about brain metastases and how can we study that further.
Okay. And speaking of those next steps, what do you envision the phase 2 is going to look like? Will this be a multi-site trial? Will it allow Optune users? All those kinds of, what's the vision for phase 2?
Yes.
And the timeline.
Yeah. So phase 2 in my ideal world, we would target, 2025, end of 2025 to open, but for people who have run clinical trials, there's many logistics involved. And I think we definitely want to make sure that it's set up the right way. Phase 2 will definitely be a multi-center and looking at, perhaps looking at patients in the newly diagnosed setting and allowing for Optune or looking at other combinations. What is great is we have all these ideas and we have a clear direction we want to go, but there's always those opportunities to start looking at some smaller investigations as well. So I would say 2025 will be a big year for us.
Okay, and I think I had read a paper maybe by Dr. Chitambar about potential synergies, with oral gallium maltolate and maybe metformin, for example. Are there things like that you're envisioning already researching or looking into researching more in the future?
Yep. So that's exactly one of those little side projects that I was talking about that, we have this vision for the phase 2, but you're absolutely correct. Gallium maltolate works on mitochondrial complex 1, and metformin does as well. And so we've already been looking at the preclinical data in that regard and really do want to start looking at a phase 1 sort of opportunity of using that combination.
Okay, great. And I think what a lot of people want to hear about, because obviously the phase 1's really, really small and phase 2 is a long way away. So in the interim, for those that, aren't eligible for the trial necessarily, can you tell us a little bit more about the expanded access program? Who would be eligible for it, and when do you anticipate it opening? Those sorts of things.
So the expanded access program is our focus right now. I feel like we have many focuses, but that's why I have such a big team. So we are currently designing the protocol or writing the protocol as we speak today, and look to make it available for malignant brain tumor patients who have exhausted standard of care and have progression of disease. And we're working through those finer details. Our hope is to have it open in the coming months rather than next year, and just to continue to collect information in terms of safety data and see how well patients tolerate it.
And I know Musella Foundation gave a grant to help launch the expanded access program. But I know they are very expensive to run and obviously administer. So do you anticipate that there will be a cost to patients to participate in the EAP?
Yeah. So one of the things about EAP is the drug cost is not covered by insurance typically. So we are looking for funds. We're looking for donations to help offset the cost for patients. But we're trying to minimize that cost to patients as much as possible.
And on that note too, will it require, you know, same as participation in the trial, will it require that sort of frequent upfront travel to Wisconsin, or will it be a little bit more flexible on the travel front because you're not doing the trial testing?
Yeah, so the goal with the EAP is to have it more accessible to patients. And basically, any institution or physician that wants to be a part of the EAP can apply for that and go through their own sort of internal process for running a clinical trial. Essentially, it's a clinical trial through the EAP that has their own regulations, but patients would be able to travel then hopefully more locally and not have to make the trip to Wisconsin.
Wonderful. I think unless any more questions roll in, I think that was all the questions that came in through the chat. But I just wanted to thank you so much for you know, sharing all this information with us. And you know, just to anyone who sees this, we are accepting through the Musella Foundation, we are accepting donations towards funding the EAP program to offset the cost for patients. And those can be made on the virtualtrials.org website. And before we close tonight, I also just wanted to thank you so much to Samantha and Tim and to Linda and Al for joining us and sharing your experience with the trial. Great. Thank you all. Have a good evening.
Thank you.